Hi there, I'm Professor Chapman, Michael Chapman. I'm an IVF specialist with IVF Australia. I've been doing IVFs for 35 years. It was the first time I did my embryo transfer was in 1985. So I've seen thousands of babies born after IVF. Tonight we're going to talk about the babies that we have created over the years. And we've created very many babies, both in IVF Australia, in Australia as a whole, and internationally. It's been an amazing number. So let's get started. We'll use some slides. You won't see my beautiful face very often here until we get to the question and answers. So during my talking, if anybody's got any questions, please log on to them and put them on the Facebook page, and we will answer them, and I'll do my best to answer them when we get to that point. Tonight I've got Rebecca with me, and now Rebecca was a IVF child who, as we will see, let me think if I can show her that she's sitting right next to me, is a grown-up IVF-ling. And more important than that even, is that subsequent to her IVF, she's now had 2 children, 10 and 8 years of age. And she was lucky. She didn't need IVF for those 2. So it just shows that having a baby through IVF still ends up with a normal person who can have normal babies into the future. So Louise Brown, who was the first IVF baby back in 1978, she now has grandchildren as a result of her being conceived through IVF, but a daughter conceiving naturally. So it's a wonderful thing that we're going from generation to generation of children born through the IVF process. The information about the children of IVF is massive. And the reason is that when we started doing IVF back in the early 80s, it was regarded as an experiment. We were interfering with nature. Many people thought this experiment was a Frankenstein exercise, and so it's been very important that we made sure that when we had the children, when we created the children and they were delivered, that they weren't some monsters with one eye in the middle of their head and all that sort of stuff, because that's what people were predicting, that we were going to interfere, and in the process of interfering, we would create something that we shouldn't have. So they've been studied in fact, they are the most studied group of children ever created. Pediatricians, geneticists, epidemiologists have been following children up across the world for the last 40 years, because we are 40 years on. Louise Brown, in fact, is 42. Our first baby in Australia was Candice, and she's 40 years of age. Rebecca, I won't tell you what her age is, but was close behind her. Okay, so let's go through these slides. So we're going to share the screen, and here we go. So we've introduced ourselves. So what about the babies? So how many? And this really is reassuring. So around the world, it's estimated there have been more than 8 million babies born through IVF over the last 40 years. In Australia, almost 300,000 babies, 300,000 people who wouldn't have been there and if there hadn't been IVF. I always compare that to various cities in Australia. There wouldn't be a Hobart if there wasn't for IVF. We're now contributing 1 in 20 babies born in Australia has been conceived through IVF. So we're making a big addition to the population, but obviously we need to know that they are normal. And as I say, the evidence overall is very, very positive. So the pregnancies that that women go through when they get pregnant with IVF, are they different to the rest of pregnancies conceived naturally? In most ways, they are similar. The babies grow, and the incidence of high blood pressure is no different. The incidence of diabetes is no different. There is, however, some evidence that the placentas from IVF babies don't do quite as well as a normally conceived baby. And it is obviously a major disaster if the placenta gives up and before the end of pregnancy and before delivery, which results in a stillbirth. And unfortunately, stillbirths do occur more commonly after IVF conceived pregnancies. These stillbirths are usually right at the end of pregnancy, even beyond the due date. So I, as an obstetrician and an IVF doctor, I make sure that my ladies are induced around 39 to 40 weeks. I don't let women go overdue who've been through an IVF. And if you're having a baby after IVF, I would be quoting me, feel free to, Prof Chapman said, that I wasn't to go overdue, because there have been surprises, and I've certainly had the saddest stories of women who've gone through IVF, struggled to get pregnant, then gone through pregnancy and ended up with a stillbirth at the end of the day. Obviously, a major disaster. So, but generally the pregnancies are similar. The next slide. So the births themselves, are they different? Well, the statistics suggest that they are. Premature is slightly more common. The average gestation at delivery is a little earlier. Now, the issue around that is heightened, or used to be heightened, by the fact that twins were much more common in IVF pregnancies because of 2 embryos back. And that's the biggest problem with twins is premature delivery. And with premature delivery comes the loss of babies because they're so premature. And also the fact that cerebral palsy in premature babies is 4 times more likely. So that's why we only put 1 embryo back. And so we've basically overcome that problem in Australia. In the rest of the world, there are still high numbers of twins being born through IVF, which is bad both for the babies, the mothers, and those children into the long term. So overall, a slightly increased risk of prematurity going into labour early, even for singletons. Caesarean sections, however, caesarean sections are more common. The average caesarean section rate for all IVF babies in Australia is nearly 50%. In the background, spontaneously delivered babies, it's only about 30 to 35%. So why are IVF babies more likely to be delivered by caesarean section? Mostly, it's about the lady and the man and the obstetrician getting scared, because obviously labour does have its risks in terms of oxygen supply to the baby. Very low risk, but it's there. And obviously by a caesarean section, we know we're going to get a good outcome. So a caesarean section based around the fact that women and the obstetrician get nervous is probably the main reason. The other contributor is actually age. And even in the normal population of conception, normally, once a woman gets over 40, the caesarean section rate also rises up towards 50%. So that's contributing to that increased risk of a caesarean section. It's not essential to have a caesarean section, that's for sure. But any sign of any problems in a baby that's been conceived after IVF, obviously we're not going to take any risk at all. So that's why caesarean section is more likely. So the babies, are they different? So birth weight. the weight of babies through IVF in the fresh transfer seems, for reasons we don't quite understand, but it may relate back to what I said earlier about the placenta not being quite as good in IVF babies. The birth weights are slightly lower. Overall, 150 grams. Now that's peanuts. I mean, instead of 3.2, it's 3.05 kilograms. So it doesn't make a difference to the health of the baby. But that's the statistics. Although interestingly, and we'll come to this again and again, when you look at babies born or conceived in mothers who've had trouble getting pregnant but haven't gone through IVF. So these are the infertile who've got pregnant after 12 months of trying, who haven't had to go through IVF. When you look at their birth weights, they are similar to IVF birth weights. So while IVF gets blamed for various things, in fact, it's probably the infertilities that's the issue, not the IVF. And that's true of the next issue, the issue of congenital abnormalities. When we started being able to use sperm of very low numbers to get pregnancies using the ICSI technique, people noticed a rise in congenital abnormalities. So this is probably related to the sperm. And that's probably true. In the severe male factor problems, there is a slight increase in congenital abnormalities, albeit it's moving from 2.5% in the general population to 4% in severe male factor issues. In IVF for all other reasons, it's 2.5 going to just over 3%, so a slight increase. But when you look at the infertile population who conceive naturally, you get the same slight increase. So while the doomsdayers said that IVF was going to create all these monsters, they were wrong. And we can be very reassured about that. Just going back to birth weight for a moment, one of the things that we do know, which is interesting, is that when we use a frozen transfer as opposed to a fresh transfer, birth weights are the same. Something's happened that's better in a frozen cycle. Again, it's not statistically important for an individual, but in overall population studies, that's what we've shown. So the children are born and they're followed up. And as I said earlier, these children are the most followed up children in the world. There are cohorts of 1,000 or 2,000 IVF children that have been followed through the first 5 years of life, the first 10 years of life. And last year, or the year before last, sorry, a group in Melbourne looked at about 150 teenagers and early adults to see how they'd gone. So the things that pediatricians look at are the milestones, you know, when do they first walk, when do they first talk, all those sorts of things. And IVF children are no different to the rest of the population. In relation to intelligence, the data out of the Melbourne study, as these were teenagers, was that in fact their IQs might be slightly higher. Now that might be biased by the population who 15 or 20 years ago were going through IVF, where the government subsidies weren't quite as high, so it was really the people with more money, and potentially they came from private schools and all that sort of stuff. They may have biased that population, but in any way, so they certainly don't do worse, and they appear to do potentially better. So that's all very, very, very positive stuff. We don't need to worry that our children born through IVF are going to be that different to anybody else. Sorry, that part of that, and this is the adult work. Sorry, let's move on. The adults, and again, that comes back to that study from Melbourne, but there are also other studies as well showing that those people who've been conceived through IVF are now in their 20s. looking back on their lives and their psychological status, no different from the rest. They all have their group who are depressed, their group that are anxious, but they're no different from the general population. The other concern was that we might be creating babies that might in the long term have an increased risk of diseases. We're talking about blood pressure, we're talking about diabetes. And to date, there is some evidence in some of the early IVF, and that's the other problem that we have in assessing how things have gone, is that IVF, in terms of culture medium, in terms of the growth of the embryos, has changed a lot to the better in terms of success rates, and probably to the health of the children, because we're mimicking nature much more and more. So, but there were some studies that showed that blood pressure was slightly higher than in the general population, and that there was some teenage work out of Holland and in New Zealand that diabetes or tendency towards diabetes was slightly higher. But we're going to have to wait and see where that plays out, because if you think about it, Louise Brown's 42, there are only about 5 more babies born in the next 2 or 3 years. So there's only a group of babies that are around 40, who are now 40. So we really don't know. And that also leads on to life expectancy. We don't know what that all means, whether we've done something dramatic. But the evidence so far is not. I mean, you would have, if there was a disease that was going to start having an impact on life expectancy, there would be people already starting to fall by the wayside, and that has not been the case. But it was, when I started doing IVF, it was an experiment, and that we regarded as sort of on the edge of science, Frankenstein's. But I think what's been proven subsequently, and given, with 8 million babies around the world, if there'd been a problem, it would have shown itself by now. So we can be very comfortable. The children that we create after IVF, the children that you have after IVF, will be normal. So I think we'll finish there. So I hope that's been reassuring for you all, and I'm happy to have any questions.
Well, Professor Chapman, we have a few questions.
Oh, jolly good.
So one of the first questions is, hi, Professor Chapman, are there any side effects for children conceived following ICSI?
So the ICSI story starts with the fact that ICSI was designed or created to deal with severe male problems, and many of the severe male problems do have genetic basis. And so there was, and there is probably in that small group of ICSI, which is a relatively small percentage of severe male factors, where there is a slight increase. And certainly the study out of Western Australia, almost a decade ago, in the early days of ICSI, these were children born in the 90s, there was this 4% compared with 2.5% in the general population. But ICSI is used much more widely now for lots of other things. In fact, 65% of Australian IVF involves ICSI, and we have not seen an increase in congenital abnormality if there's not a male factor involved.
Okay, great. So the next question we have is, babies or children born through IVF, does that mean they will also struggle through infertility?
You could talk to that one, Rebecca. No, we don't think so. As I said, Louise Brown's daughter has had 2 children without any problem whatsoever. There's no reason to think that that will be the case. There is one exception to that, and that is, again, going back to the severe male factor problems. One of the causes, and it's rare, I mean, it is really rare, but one of the causes of low sperm counts is the male carrying a genetic deletion of its Y chromosome. And if a child is born from one of those sperm, A study out of Holland 18 months ago or so indicated that the 40 children that they looked at who were male carried the same problem. And so that is one specific one where, yes, by curing the fertility problem, the infertility problem in that microdeletion group, we are potentially handing it on to the next generation. But I have to say, I tell my patients, if that's the situation, and they say, well, if you can cure our problem, our child will be able to be fine will be cured in the future. And that they are right. It's correct. So we can overcome it, but it may mean that they also have to go through IVF.
So some more general fertility questions here. We have, hi, what are your thoughts on fertility acupuncture before and after embryo transfer?
Okay, we're moving off the babies. Well, I'm a co-author of one of the biggest studies of acupuncture and the chances of a pregnancy. It's an Australian-based study. It was in multiple centres around Australia. We recruited over 800 patients. Half of them got acupuncture, half of them got what was called sham acupuncture. They thought they were getting acupuncture, but they weren't. The results, no benefit. Published in the Journal of the American Medical Association. So personally, I do not, and scientifically, I do not believe acupuncture makes a difference to the live pregnancy rate. That said, I think acupuncture does relax people in a very difficult, psychologically stressful time. So I still think it's worth doing. If you want to do it, but it's not going to improve your chances of having a baby.
We also have another question here, and that is, are IVF pregnancies more challenging?
To the obstetrician, the challenge is this is a very, very, very important pregnancy. We've created a baby and we want a good outcome at the end of the day. So some obstetricians will be quite stressed by the process. And as I mentioned in the talk, it doesn't appear as though the risks in terms of high blood pressure, preeclampsia, or diabetes or growth retardation are particularly different to normal populations. I did mention that there is a slight increase in stillbirth after the due date. So the only difference I would say is make sure that you get delivered before your due date. It just reduces a long shot into a very, it doesn't reduce it, it removes a small risk, but obviously a devastating risk if you lose your baby at that point.
Another question we have here from Jenna is, my partner and I wish to have another baby. I have tubal ligation and I've had 3 previous healthy babies. Is this possible?
Absolutely. That's what IVF's designed for. And I would suggest you've got a very high chance of pregnancy. Obviously, age is your biggest issue. If you're obviously over 40, the chances are going to be lower. But if you're under 40, high chance of getting pregnant.
That's great. Another question we have here from Ellie is, hi, how much does your CRP marker affect implantation? I fell pregnant last cycle, but I lost the baby and then I found out I had pneumonia and a very high CRP level. Thank you.
I don't think anyone knows the answer to that question. I don't think CRP in itself is I mean, it's just a marker of inflammation. But, you know, if you're unwell, then at the time of implantation, you probably are standing a lower chance of getting pregnant. It's not the CRP in itself, it's the general wellness of you at the time. But hopefully you get over the pneumonia and hopefully you've got another embryo in the freezer and you'll get pregnant.
And just a few more questions before we finish up. We've got one here from Camilla and she's asking, thank you so much for doing this talk. I'm 38, my husband is 45 and we're hoping to start IVF next year. Any advice for us? We're both healthy and hubby is losing a lot of weight.
Oh yeah, it's very good that he's losing weight because his long-term health will be good. Whether it changes his sperm quality, yeah, it's debatable. But anyway, no, it's healthy living and good lifestyle, not too much alcohol, not too much coffee, but still have some. I'm a man who says moderation, everything in moderation. People say stop everything. Well, that's not true. Well, I'd say it was true about cigarettes, but because that is damaging. Yeah, be healthy. I wonder why you're putting it off till next year. I mean, the sooner you get going, the better. Age is an issue, and that once you're 38, your egg quality is declining, not rapidly at this point, but certainly by the time you get to 40, it's starting to fall away quite quickly. So if you're going to have a baby, get on with it, would be my view. Obviously, I don't know why you need IVF. Most people contemplating pregnancy will probably be okay. IVF's only for a small group who fail to conceive. But so what should you do? Try now.
Okay, so the next question we have is from Kath. Thank you for this session. How difficult is it to be a successful recipient of egg donation at the moment?
It's dependent on the age of your egg donor. If you're lucky and you've got a younger sister who's 25 and you're 45, then your chances of pregnancy are the same as if she'd had a pregnancy, provided everything else is normal with you. So, when we use 25-year-old anonymous donors, if we can find them, pregnancy rates are very good, like 50+%. But it is dependent on the age of the donor.
And one more question here we've got from Danae is, are you better to transfer a day 3 or day 5 embryo?
Okay, so everybody used to transfer day 3 embryos, because we didn't have the culture. Let's go back just over a decade. We all were doing day 3 transfers because we weren't confident that the laboratory was capable of growing embryos on beyond that time. Culture medium hadn't been developed that was appropriate, and so we didn't grow them on. Gradually, we realized that technology improved, and what we realized was that if an embryo grows in the laboratory in conditions that mimic being inside the woman's fallopian tube, the embryos that we end up with at 5 days have got a much higher chance of producing a pregnancy. And that's because the ones that don't grow to day 5 probably would have failed if we transfer them on day 3. So it's a bit of a selection process. It's an obstacle race, and if you get to day 5, then you're a better embryo than those that don't make it. So if you transfer day 3 embryos at the end and you freeze the remainder, if you've got embryos to freeze, then ultimately transfer after transfer, you end up with probably about the same chance of success, because the day 3 embryo that would have grown onto a day 5 is still there. And you're the incubator for those last couple of days rather than in the laboratory. But on the way, you're going to go through cycle after cycle of embryos that were not up to scratch and would never have made it in the laboratory to day 5. So in Australia now, 85% of embryo transfers are done with day 5 embryos because we think it's better. Time to pregnancy, time for your pain of going through a cycle and failing is reduced, and the onset of a pregnancy is going to be quicker if we use blastocysts. So that's why people have changed. Some clinics still believe in day 3, but my concern is that those laboratories really haven't graduated into 21st century modern laboratories and haven't taken on blastocysts in the way that the rest of us have.
And we've also got another message here from Camilla just to say thank you so much for all of your advice that you're providing. And we have a lovely message from Diane. She's one of your patients. She said, "We'd like to thank Professor Chapman for our beautiful Angelina, who is now 3. We are also doing 10-day post-transfer and having bloods tomorrow. Fingers crossed." Thank you so much, Professor Chapman.
Well, we're all waiting with bated breath, and hopefully it'll be another positive.
And then I've just got one more question just in relation to progesterone, which is, sorry, let me just find it. Does it always work in the transfer?
Well, of course it doesn't always work, because that's not really the determinator, what causes a pregnancy to occur or not. It supports a good pregnancy. What we found very early, back in the 80s, in fact, was that when we stimulated cycles to produce multiple eggs, the second half of the cycle was very abnormal, that we pushed the estrogen levels with the multiple follicles way above what normally happens in a normal menstrual cycle. And when we collect the eggs, those follicles collapse and the progesterone levels fall dramatically. And that dramatic fall, in about 50% of patients, if it's not supported, will lead to the lining of the womb being lost, breaking down, and obviously any pregnancy that was there would be taken away with that. So routinely now, we do give luteal phase support in a fresh IVF cycle. By not using it, we will lose many pregnancies. Now, in frozen cycles, where we're putting an embryo back and the woman has produced 1 egg in it as a normal natural cycle, the progesterone levels are appropriate. And so we don't need progesterone to be added on. Many people do it as a belt and braces, and certainly I do in older patients, because in some older patients there is a deficiency of progesterone, even though they've ovulated normally. So it is important in fresh cycles. It probably isn't so important when we do a frozen transfer.
Fantastic. That's
all right, that's all the questions. Well, thank you all for very much for listening. I hope it's been useful for you, and it's great that we can provide this sort of education for you, and we're more than happy to be consulted. I'm certainly available both face-to-face or by teleconference. And as part of that education process, which I believe is very important, I personally do a weekly podcast that you might be interested in listening to my dulcet tones, 10 or 15 minutes every week. If you go to iTunes, and it's called The IVF Journey. And I've covered 180 topics, I think it is now, related to infertility. And many people have reported it's been useful for them. I've got nearly 120,000 hits, downloads, and over 10,000 patients have used it. So join in and be educated, because I believe the stresses of IVF really are reduced if you know what's going on. As much as we try in our individual consultations to convey information, it's information overload, and it's very useful to have a secondary source of information, either reading on the IVF Australia website, or, as I say, through my podcast, The IVF Journey. Anyway, thank you very much, and thank you, Rebecca.
Thank you.